This conference will now be recorded.
I know, I feel like there were so many conferences or talks that was like, oh, the COXY prevalence here, and then we all immediately walk outside and, it's great.
Dust blowing everywhere.
Yep.
Yeah, well, apparently it peaks in early fall after it's been really dry in the summer, and then people go
Good.
back outside, but we'll see.
Excellent.
All righty. Well, I see Seth's on too, so we can go and get started. So either of you can go first.
I can show some, just give me a sec to.
Oh, yeah, I can go. I have to do some cardiacs soon.
Okay.
Yeah, so
Yeah, you
let's
should
let Seth
go.
Okay. Which tab is it? This one? Come on. Window. I'm sorry. I'm just trying to select it. It's not. There we go. So this is a.
I don't see your screen. There we go.
Oh, you don't? You don't? Okay.
Just
I've shown a couple of these cases in the past, and at UCSD, and nice to know that this imaging appearance remains pretty constant no matter what institution you're at. So this is a patient who came in a couple of weeks ago with this very striking peribronchovascular ground glass opacity, and it really does, hug the peribronchovascular perilymphatic interstitium. Just trying to see if I can just draw it along the axis of one vessel. And I've seen this a couple times in other cases I've seen. It's often associated with some pronounced bronchiectasis, but here it's not. And every time I've seen this with this kind of opacity surrounding the peribronchovascular interstitium, it is held to be pretty constant secondary to polyarteritis nodosa with MPO. So with that specific, I don't know if the MPO is an associated antigen, but all the cases I've shown from UCSD that had a similar look are also PAN with MPO or MPO positive. And over time, these airways will become dilated and bronchiectatic, presumably secondary to the peribronchovascular inflammation associated with the vasculitis. Not much to add, but it's just a nice example of that. Anyways.
So Seth, I've not seen PAN in the lungs, but so is this a mix of microscopic, like small vessel and medium vessel disease then?
Yeah, it's basically microscopic. Sorry, it's not really PAN. It's microscopic polyangiitis with MPO positive.
Got it.
It's not really I'm sorry, it's not polyarteritis nodosa. It's microscopic polyangiitis. I'm sorry.
I follow.
Yeah, my bad.
Yes.
Still half asleep. Sorry. Yeah, I'm not getting back to work today is always a little difficult. But yes,
so this is not in the setting of acute hemoptysis or anything. This is just with active disease.
No hemoptysis. Yeah, and this imaging appearance has been going on and getting worse for about 4 or 5 years.
Okay.
And then if you remember, I don't have them with me, but the cases I showed from UCSD, like over time, these airways would get really bronchiectatic, and which is a kind of a common progression with them. Sorry, I don't know why I said. Anyways, this is a really weird case, and
Seth,
I'm not.
Sorry to.
Yeah.
I just joined. What was that last case? A classic example.
It was microscopic polyangiitis with MPO positive.
Got it. Thank you.
So this is let me see, 2D filter, sharpen this a little bit. This is a weird case I'm going to be about 10 minutes, of a patient who came in to actually, I think UC, and has this very pronounced, random nodular pattern. I don't know, nodules kind of becoming coalescent, these areas of kind of consolidation. There's ground glass. It's slightly upper lobe predominant, although it's kind of relatively diffuse. And they didn't know what it was. They ran every infectious marker they could think of, and nothing came back positive. They thought it could have been some sort of hematogenous spread of something like some granulomatous infection, and they treated the patient with steroids, and this completely melted away, just completely disappeared. Still didn't have a diagnosis. There's some effusions. Also, there's some lymphadenopathy. You can see they biopsied the lymph nodes, came back just inflammatory changes. Now, interestingly, the patient came back a few months later. So when they stopped the steroids, it recurred with a vengeance, but in a very different pattern. And you can see these areas of more nodular mass-like consolidation, some of it peribronchovascular, air bronchograms, through some of these nodules, areas of consolidation and surrounding ground glass opacity. Now, this just underwent and there's also some septal thickening. So, I gave a differential, number one being vasculitis, and then I got into, just because of the rapid change and improvement, I got into some other weird things, and eventually ended with saying, lymphoma. If I just had this appearance, it could definitely be lymphoma or lymphomatoid granulomatosis, but I can't explain the change between the two studies. Anyways, this just came back from biopsy as lymphomatoid granulomatosis. I'm still a little confused. Now, this looks like it. I mean, it's in the differential. I mean, it's such a rare entity, but these areas that look like lymphoma, with some areas of ground glass, but I can't explain the evolution from. Now, interestingly, when I looked up this, the cases I have of LG, which I think I have 4 or 5, not many, they were bad acting. The patients died from them. It was really bad. But it turns out that with the biopsy, said it was low grade. And it turns out low grade LG can actually be exquisitely steroid responsive and get a lot better, but does recur. So I'm still a little bit, I asked our pathologist if they can kind of elucidate a little bit further, because I'm still not 100% buying LG. But have you guys ever, and again, I don't have many longitudinal studies of people with LG, but I haven't seen evolution like this.
No, I haven't seen. I haven't seen a case in many, many years.
Yeah.
I was wondering, I don't know the answer to this, and maybe that your pathologist elucidated or clarified it. Is it possible to sort of undersample lymphoma, or is it very distinct?
So, and that was a question, right? Could it be lymphoma? And then the weird thing is that it literally, I mean, I have a chest x-ray intervening where you could see the nodules just completely disappear. And then, I was saying, because I was talking about it with Lynch just a minute ago, he's like, well, I've seen lymphoma do that too. Low-grade lymphomas melt away with steroids. I don't have the experience with that, but if he says it happens, I'm sure it could. But I'm still waiting. Maybe they have to go in and biopsy again. I don't know. And the pathology was from an outside place, which is actually very good. It's another academic institution with good pathologists. I wrote our pathologists, see if they evaluated it as well, see what they say. All right. This is an interesting case because, let's see, which one is which? Oh, this is a cool case. So this is a patient I saw a couple of weeks ago and I saw this and I'm like, diffuse central lobular nodules, upper lobe predominant, no mosaicism. The kid's like 22, and there's a differential. There's, of course, you think something inhalational. It is upper lobe predominant, and the first thing that popped in my mind whenever I see a young kid is, could this be EVALI? We do still see cases, not as frequent. So I wrote the I said it could be HP, something else inhalational. It doesn't look like regular smoking stuff. It's too extensive. So we got the outside study, which was actually also done just down the road at UC. And here he was 2 weeks before. So, I said this really, whatever you want to talk about, areas of sparing, peribronchivascular, subpleural. This looks like kind of that classic mixed pattern we talked about in our paper. I mean, pretty classic, especially with the evolution to one to the other, literally over a short period of time. So I talked to the clinician, and the clinician's like, he denies vaping 100%. And I'm like, well, ask him again. And he's like, he denies vaping. And I said, okay, well, maybe you have to biopsy him. He's like, yeah, I guess we do. So he went to the guy and he's like, listen, we don't know what it is. It looks like vaping lung injury, but you're saying you're not vaping. We want to do an open lung biopsy. And then, of course, he admits, he's like, okay, I don't want an open lung biopsy. I was vaping and I've been vaping. I got really sick. I bought a new cartridge like 4 days before I came to my first appointment, and I got really sick after vaping it. And yeah, so this is probably evolving EVALI from a kind of a more mixed pattern to a more kind of classic airway pattern, or not airway pattern, airspace pattern, where you get these areas of organizing pneumonia around the respiratory bronchioles. So, but I always this is like the third case where I've seen in the past maybe year and a half where patients deny. It's pretty classic imaging appearance. And then when they get threatened with biopsy, they finally cop to it. And then last, really quick, this is an 18-year-old non-smoker, pretty horrendous panlobular emphysema, lower lobe predominant. All his alpha-1 antitrypsin things to date have been negative. And here's his dad. Who has more of a, so you can get this kind of bronchiectasis, stream bud nodularity also with alpha-1 antitrypsin. His alpha-1 antitrypsin was also negative, but it turns out I didn't realize this, there's a lot of different genes associated with alpha-1 antitrypsin, and they only really test for that, like the 2 or 3 most common genes. So there's a place in Italy, again, this is all new to me, where if they still highly suspect it, but everything is negative, they send it there and they do testing on all the genes that are associated with alpha-1 antitrypsin. And sure enough, both the father and son have the same genetic mutation, and both have alpha-1 antitrypsin, despite them being told for many years that all their genetic testing was negative. So
That's really cool.
I thought that was really, and the kid is like 18, the dad's like 42, and both of them are forever, both non-smokers, never touched a cigarette in their life.
So is there a move to get those tests here, or are they genes that just aren't common in the U.S. population, or what?
I don't know. I mean, I was surprised to find A, that there were so many mutations associated with it, and B, that even here they don't do them. Usually we're the place that does all the weird things like tests, like we get stuffs, part of the way we stay solvent here is by running weird tests that no one else runs. And I was surprised that we don't even do them here, and we send them elsewhere. And I don't know, outside the country, and I don't know the answer to that. But it's interesting because there's all these cases I remember seeing that are so slam dunk alpha-1 antitrypsin, and the tests come back and they're like, oh, it's negative. Their genes the test came back negative. And you're like, really? I mean, it's so classic. And I didn't realize we were only testing the most ones that are associated with like 75% of cases. Like there's a whole slew of genes we don't test for. Anyways, I really thought that was neat. That's all I got.
Awesome. Thanks. Those were great. All right, Maya, you ready now?
Sure.
There you go.
Okay. This one. Okay. So I'm going to start off with a very classic imaging finding that we see a lot because I think it pairs nicely with the case that I'm about to show, which is this patient here. I actually don't even know what their history was, but they were getting a PET CT and they have, this area of soft tissue that's sort of underlying the tip of the scapula underneath the normal musculature of the chest wall, sort of between that rib and that scapula. They have it on both sides. So a really classic look for an elastofibroma dorsi on both sides here. And as we know, right, on PET, they can be a little bit hypermetabolic, just like we can see here. So classic appearance. I read this CT a little while ago on a different patient who has cancer. This is a restaging CT and has soft tissue in almost the exact same location. But if you'll notice, it's a little bit more posterior. It's not right between the tip of the scapula and the rib. And I think this is something that we had overlooked on prior scans, thinking that this was probably that same process. But if I can show you here, sorry, here's that scan that I was just showing you. And then this is a scan below, which I'm going to pull up, which is from 6 months before. And you can see that on the current exam, that area has nearly doubled in size. So I don't know about you, but I've never actually seen an elastofibroma dorsi grow, at least not this quickly. And you'll notice, right, that this patient has other problems. They have a bunch of these lung nodules, very large. And in other parts of their soft tissue, like for example, back here, they have soft tissue implants as well. So this is a patient who has metastatic melanoma, and this was just a metastatic implant that was sort of nicely mimicking an elastofibroma dorsi, but again, it's a little bit too posterior, not right between the scapula and the rib. But just a good, always make sure things are not changing more rapidly than you anticipate.
That's a good case. I've never seen elastofibroma grow or just appear overnight.
Exactly. Yeah. Like I'm sure if you go back many, many years, it obviously pops up at some point, but yeah, this was really fast. And then they got treatment. They were started on a new or different immune therapy and it did shrink back down. So again, suggested that this is actually just a met. Just a very sneaky one. All right. And then I have one other case, which would be great for Travis, but he's not here, but that's okay. So this is a woman, I think in her 60s, who has on CT some areas of sort of discrete nodules, like this little oval nodule in the right upper lobe. It does look like there's an associated airway with that nodule. And she's got a bunch of these, relatively small. I think that right upper lobe one is the largest, but the more you look, the more you see of these scattered solid pulmonary nodules. You'll also notice, especially if I window it a little more harshly, that she has got quite a bit of mosaic perfusion. So these nodules have been there for quite a while. They've very, very slowly grown. If I go back to 2021, I think that largest one has grown by a couple of millimeters. So really slow growing, multiple nodules plus mosaic perfusion. So this is a really good look for DIPNECH or DIPNECH. And the thing that I actually thought was really interesting about this patient is you may have noticed as I'm scrolling through here that she has sutures in her left lung. And that's because she's had a left lower lobectomy because she actually originally presented back in the 90s with carcinoid syndrome. So she presented with flushing and wheezing and diarrhea, and that's when this diagnosis was originally made. And she used to have a larger lesion in the left lower lobe. We actually don't have her pre-imaging from the 90s, but that got removed, resected, and pretty much immediately after the surgery, all of her symptoms went away. So that's the first that I have heard of DIPNECH presenting with actual carcinoid syndrome. And so now we've just been following it. She no longer has symptoms and, not a lot else to do for her unless she develops symptoms again.
It's funny you mentioned that, Maya. I had a case recently of a patient who had, it was billed as metastatic neuroendocrine tumor of the lung, which when I think of that, I think of small cell lung cancer. Because, I mean, I think I can count on one hand the number of carcinoids I've seen with like a lymph node mets, but never like widespread.
Yeah.
And, you know, in retrospect, it's DIPNECH. And that patient did have some symptoms, I would believe. But you're right. You don't typically, I don't associate pulmonary carcinoids with metabolic activity.
No.
Because they're usually, you know, metabolized by the liver and they don't usually metastasize. But I've now seen 2 cases of DIPNECH in male patients that in the last year. And, you know, I mean, I think there was that large series that Brent Little did, I think, and it's like nearly all female patients.
Yeah, we've seen a couple of males.
Yeah,
much less
it's
common,
probably
yeah,
underdiagnosed.
Yeah.
Yeah, well, that's for sure. Yeah. We've had ones that are, I always, you know, occasionally like they almost become metastatic and they grow and they get multiple and then you wonder, I don't know. There's this line somewhere between just these benign carcinoids. There you get small airway obstruction from the neuroendocrine tumorlets and other things, and they release some fibroblastic factor. And then sometimes they're not, some of them, I guess, I don't know if they get another mutation or something, but they're aggressive and they can spread. And they treat those with whatever the systemic therapy they use to treat metastatic carcinoid tumors with, and they do really
like
well.
Dotatate or whatever.
Yeah, that's exactly right. Because we've seen a couple of them, and I guess there's a DIPNECH specialty center here who figures. Because, you know, again, I've seen a few cases, but like, oh no, we've seen it where it spreads and it becomes aggressive and almost becomes metastatic, and we treat them with the systemic therapy. Anyways.
Interesting. Very cool.
All right. Well, thanks for those cases.
Yeah, thank you.
David, do you have cases this week? All right, well, I will go and then we'll check back with David. Let's see here. Okay. Share.
Jeff, I do have cases, so when you're done.
Okay. So I've got 2 cases with the same, I lost my list. Here it is, with the same diagnosis. So these are some interesting ones. So I'll start with this patient. This patient had a history of a spindle cell melanoma, which is a variant of melanoma, and it has these spindle cells. And on surveillance imaging was noted to have this new nodule at the bifurcation of the bronchus intermedius. Of course, melanomas like airways. And on metabolic imaging, they were just seeing if there were mets anywhere else. This thing is very hypermetabolic. So they went in and there it is on the bronchoscope. And so they biopsied this, and it was a spindle cell neoplasm. And it took a lot of creative immunocytochemistry on the part of the pathologist to work this up. But ultimately, this was determined not to be a melanoma, but rather an inflammatory myofibroblastic tumor of the airway. And, you know, these are sort of like the old pseudo tumors. That's the name, the now preferred name for them is inflammatory myofibroblastic tumor. They're not neoplastic or malignant in a sense. And, you know, it was removed bronchoscopically. So it wasn't a metastasis, but in this particular case, the diagnosis was challenging because it had some morphologic features similar to the original melanoma. I don't have the path to share with you, but there were all these different stains and things you can do to work it up. Interestingly, we got a second case on the other side. Now, this patient did not have melanoma, but presented actually coughing up blood intermittently. And she had this cough. And so on CT, we found this endobronchial lesion. And so they went in with their bronchoscope. You know, we're thinking, you know, squame, things like this. And it actually had popped off. Like when they put their scope in there, it just dislodged. But they were able to retrieve the tumor mass. And you can see what's left of the airway here. There's a little bit of it there. This was another inflammatory myofibroblastic tumor. So 2 of them in the airway. That's added to your differential for airway nodules. This patient was a never smoker, young patient. But I mean, there's nothing specific about the imaging, and it's not, you don't always see them here. I've seen them in the lungs a few times, but these are the first two I've come across in the airway in a while. So 2 cases of that. This is a neat case. I thought this was a great call by somebody on the radiograph. So this patient presented with chest pain, and there's the frontal radiograph of the, and then here's a previous one for comparison, an older image there. And you can see it doesn't look terribly exciting. And I'll bring in the laterals here. And this is where I thought someone made a really nice observation. If you look behind the sternum, I'll make this bigger for everyone. There we go. There's this kind of ill-defined rounded thing that was not present several moons ago. So they questioned a mass in the mediastinum or somewhere like that. So the patient went for chest CT. And what we found on CT, and the CT was probably a few days later, is this thing here. You can see it's kind of soft tissue with fat in the middle there, very well demarcated. And the patient had localizing chest pain to this area. So this is a case of mediastinal fat necrosis, pretty typical appearance, but I don't think I've ever seen a case on a radiograph before. So kudos to the radiologist who picked that up.
That's
why it's good to have a comparison and always look in your retrosternal, retrocardiac, and retrotracheal clear spaces. So mediastinal fat necrosis, benign, give them some NSAIDs and send them on their merry way. All righty.
There was a left pleural effusion along with that too.
Yes. Sorry, I should go back and show that. Where did I have that? Yeah, right there, a little blunting of angle there. Yes, and that's another finding that can be helpful because it does irritate the pleura, and that's why they get the pleuritic chest pain. So this case is an interesting case. So this patient had a cough and got a radiograph, which you don't have, and they saw some abnormalities. And so if you look at this CT scan, there's these 2 nodules, big nodules here in the right upper lobe. But if you look around this right upper lobe nodule, you'll see there's a bunch of little satellites kind of along the lymphatics. And then on this one here, you see kind of a similar thing. And there's a little bit of septal thickening. So there's some lymphedema and some nodules along the lymphatics. If we look at the mediastinum, the hilar nodes are not enlarged. The mediastinal nodes are enlarged, and there's no pleural effusion. So when I've seen this appearance, I've always thought of histoplasmosis, but I'm a little bothered by the fact there's 2 of these. I still think this is granulomatous, but it would just be odd to have 2 nituses of histo, but I think it's a reasonable differential diagnosis. So they got this, they biopsied this on, I think they BAL'd it and did a transbronchial biopsy. And this is not histo, but it is a fungus around here. This is one of the odder cases of blastomycosis I've come into contact with, where presenting with these 2 dominant nodules. Usually we see consolidation. I've seen it present as a solitary nodule that looks more like a lung cancer. But in keeping with blasto, you don't tend to get a lot of lymphadenopathy, unlike histo, where it tends to be disproportionately more severe. So blastomycosis presenting as 2 nodules, but those satellites are so helpful, I think, in pointing to a granulomatous cause. And so there was a nice talk on histo at the STR this week, and they described this appearance. I think someone used the term frogs on a log. I've heard ants on a log, but it's just there's probably the tiny lymph nodes and stuff. There's, as the organism is ingested by macrophages, they drain along the pulmonary lymphatics. But usually with histo, you get quite exuberant lymphadenopathy from the neoplasm. And then this last case is a cool case, and I don't know if Seth's still on, but he'll like this one. This was shared with me by one of my colleagues, and let's see if I can get this is an example of a duplicated circumflex coronary artery. So if you, let me see, I don't know if I have to get it to the best phase. This is the whole stack here, but let's see if we can get a decent time. So if we look on the left main, there's some plaque, there's the LAD coming off, and then there's a little branch here that continues as the circumflex and goes down. But then there's this other branch that comes off the cusp separately back here that comes down on top. And so this bigger branch seems to become an OM, and then the smaller branch continues down as like a small posterolateral branch. And this is one I've not seen before, but I don't know if anyone's ever heard of seeing a duplicated circumflex coronary artery. Just an incidental finding, but would be important for a cardiologist if they're doing a diagnostic or if they're doing a cath to know that there's two separate circ branches. All right. All right, David, are you ready?
I'm ready. Can people see a scout view?
Yes.
So this is a fairly young guy. I don't have his age right in front of me, but he does have this rib lesion. This CT scan is in the last year or so. He had a 2013 CT scan that showed no such rib abnormalities. So we seem to have an expansile lesion in that left rib. And here it is on coronal view. You can see this rib is very expanded. There's a little hint of a ground glassy matrix, but it's not throughout. And on PET imaging, it is barely warm. You can see just a little bit of uptake in it. It's not very hot at all. So it doesn't, despite its aggressive expansion, it doesn't seem to be that glucose avid here. And so this lesion was biopsied, and it turns out to be a fairly rare tumor for ribs, which is an aneurysmal bone cyst involving rib. And they said they thought there was a background of fibrous dysplasia. So I think the fibrous dysplasia component would go along with that sort of the fact that there is some ground glass kind of matrix to it, like this stuff here. So aneurysmal bone cyst in a setting maybe of fibrous dysplasia. In the case of fibrous dysplasia I've not seen this much expansion of the rib. You know, I was thinking that this is going to be like a metastatic kidney cancer or you know, a plasmacytoma or something like that, just because of the expansion, degree of expansion. But it was a aneurysmal bone cyst. I think that goes along then with the low activity on PET imaging. So you guys have vast collections of aneurysmal bone cysts of ribs. It's supposed to be pretty uncommon. I don't think I've seen it before.
Never.
Okay. So
I presume did they like pack it or cement it or something? Did they?
I think they took the whole thing out.
Oh, okay.
Yeah. So, you know, they had a slot in the OR, so well, let's take it out. Okay, let's do it. Got it. So this person has messy looking lungs here. This person has metastatic gastric cancer and has had a lot of these abnormalities going on for many months, a lot of these things in the lung. And then the person got short of breath and came in. And let me show you a series of radiographs. So they intubated this person. And at this point, you can see an endotracheal tube has been placed. And the person got worse, got more short of breath when intubated. And this was a paradoxical response, not what they expected. And so they took the endotracheal tube out. And you can see there are some differences in these two radiographs. Now, unfortunately, there's some rotation going on here, which confuses things a bit. But let me actually give you a different. Let me compare, instead of this image, let me show you the pre-intubation image here. So I'm going to get rid of this one. So for one thing, with intubation, the left lung gets clearer, and the mediastinum, I had some imaging where this comparison was more striking. The mediastinum shifts slightly to the right on intubation, and it wasn't that way before. So you can see that with the shift to the right, we have more consolidation going on now in the right mid lung than before, and the right base. So the mediastinum shifted a bit with the endotracheal tube, and the person felt much better when the endotracheal tube was removed. So what is going on here? Turns out there was a CT scan that was done before the person got intubated, and there was pneumomediastinum. The person had been coughing quite a bit, so that's not surprising. And here's this chronic patchy lung consolidation, which hadn't changed very much. As we scroll through here, you know, there's a part where you don't see the airway very well. And switching to a coronal view, you can see that there is actually a big metastasis here to the carina that has invaded the carina and extends to the left, mostly to the left bronchus. This person, when they bronched this person, they found that there was obstruction of this left bronchus by this tumor mass. So, you know, this lesion is so big, this lesion in the airway is so big that it was actually sort of blown by. When you're scrolling through you think well, I'm just not, you know, this is just carina or something like that. Then you realize that this is really a huge mass here involving the airway and pretty much occluding the left airway. So it turns out that if you have obstruction to a bronchus like this, you don't want to intubate the person because the pressure that you're going to apply from the intubation is actually going to force this lesion to becoming more sealing. So you can, you might be able to squeak a little bit of air past it, but you're going to make this more obstructing on ventilation. And the air that gets trapped in this left lung then contributes to the worsening of the mediastinal shift, and that's why the mediastinum shifted to the right. And the left lung became a little bit clearer on intubation because we were trapping air in it. So air was being trapped in it. So the person, if they'd known that there was this degree of obstruction, they wouldn't have gone to intubation on it. So this was part of his metastatic gastric cancer, probably subcarinal lymph nodes. You know, it grew out of subcarinal lymph nodes, invaded the carina, and then grew to this obstructing lesion that took out selectively the left bronchus. So airway obstruction here, you don't want to ventilate, you don't want to intubate a person with airway obstruction like this. So they have done, I think they've done some palliative radiotherapy to try to shrink this lesion, and the person's doing better without ventilator support, but on oxygen. So a surprising degree of obstruction of this left bronchus. So, and once you see it on coronal view, you know, it becomes obvious what's going on here. It's much more striking in this coronal view than it is in cross sections. It's really hard to appreciate a big mass like this on cross sections. So they've reinterpreted the CT scan to mention this lesion, which they sort of blown by originally. And the problem with this case, this is also instructive in terms of perception. There's so many abnormalities in the lung that command your attention, and there's the pneumomediastinum that commands your attention. By the time you get around to being open to additional abnormalities, such as a big obstructing airway lesion here, you've sort of used up your attention span, and your satisfaction of search is long. It happened, you know, hours ago. So it's very easy to miss things like this when there's so much else going on. So instructive case too for.
So David, how many satisfactions of searches do we get before we use them up?
You know, it turns out that just picking up one abnormality sort of turns off your sensitivity to remaining abnormalities. So I think the biggest impediment to detecting a left pneumothorax is having detected a right pneumothorax. Once you've done that.
That is probably true.
What?
That is probably true.
Yeah. So satisfaction of search is not necessarily your friend. Okay, this person had at this point a pretty normal looking chest radiograph, and then had fever and cough, and then had this radiograph here with this big upper lobe, mostly upper lobe pneumonia here. And on CT, indeed there is a big pneumonia with nice air bronchograms, a very dense pneumonia. Let me give you better imaging here. So a really bad pneumonia. So I think, you know, things like pneumococcus or staph or strep. And there's a component here, right lower lobe. This turns out to be Haemophilus influenza, or influenzae, which is rarely the cause of a dense pneumonia like this. Now, this person has some immune compromise. I'll have to go back and find out exactly what that immune compromise is. It's probably some medications. So this is the most aggressive and most consolidating H. flu pneumonia I've seen. What's a more common pattern with H. flu is to see in somebody with COPD is to see a subtle basal consolidation that looks kind of reticular and stuff like that around airways and stuff like that. It's more of a bronchitis pattern, a busyness that doesn't look dense like this. So that's the most common situation in which they get H. flu and they don't get other organisms. And H. flu is thought to be colonizing a lot of people. So its presence isn't necessarily pathologic. But in those settings, particularly in COPD, when that's the only organism they get, then I think it is actually pathogenic in some cases. But this was a really dense case. So let me just show you a series of radiographs on this person. At this point, it really seems to be much more extensive now, top and bottom of the lungs, and there's probably some pleural effusion adding opacity here. And then on this radiograph, things look much better. I mean, the right upper lobe seems to have pretty much cleared, and we have some stuff at the base here, and we have some effusion, so it looks a whole lot better. Well, another perception difficulty here. So let me show you what the lateral looks like at this time, and you'll see that we have complete consolidation of right upper lobe and right middle lobe, which gives us this retrosternal stripe pattern that resembles a left upper lobe collapse. And the reason it resembles left upper lobe collapse is because when the left upper lobe collapses with the lingula, the vector is drawn forward, not just upward the way it would be for a pure upper lobe collapse without middle lobe or lingula. And so we have the right lung equivalent now of left upper lobe collapse, which means we've involved upper lobe plus middle lobe, and now we get that retrosternal stripe. So this was actually much worse consolidation. It looks better on frontal radiograph, but it is actually much worse consolidation. It's now the entire upper lobe and middle lobe. We do have pleural effusion posterior on both sides. So, gosh, radiographs are just trying to deceive me all the time. It works. So worsening consolidation looking like improvement. Okay. Then I wanted to show you a couple of airway abnormalities. Jeff, I know that you're a particular fan of these. This person has this small airway that emerges from the right side
David,
of the trachea.
I'm not seeing your thing. There we go.
Is it there now?
Yes.
Yeah.
Okay, good. So we have this small airway here. I don't think this is diverticulum. It's very well, you know, it's very long and stuff like this. It goes down and it, you know, just very, very tiny little component here gets out into the lung. So this is like, and it's down going too. So it takes off and then it heads downward. So let me show you that in coronal. You can see how it has this downward course and then picks up a little bit of the right upper lobe. And we still have the normal segments of the main part of the right upper lobe bronchus here. So we have anterior and lateral, and we have an apical posterior component going up. So just a very small, funny orientation of a tracheal bronchus here. I've not seen one that looks quite like this before. Have you, Jeff?
Yes, I've seen a few, and I've seen what I call an aborted tracheal bronchus, where it does exactly, it looks like a diverticulum right at the azygous vein, and then it just ends blindly. But I've seen several of these tiny ones loop under the azygous arch, and then they have varying degrees of obstruction because of all those acute angles.
Yeah. Okay. So this is a teeny weeny one, and it, you know, it does have that nice relationship to the azygous vein there. Yeah, I'm glad you pointed that out. Okay, and then this is the last case, which is similar, and this is close to what you were describing. This one takes off from the trachea and goes into the mediastinum. and then that's it. But once again, I don't think it's a diverticulum just because of its length here. So I think this is an even more aborted bronchus than that last one, which just barely made it into lung.
Yeah,
So a
I
teeny
agree.
little one here that ends blindly, but I don't think is a diverticulum.
Right, and the diverticula have those, either invisible or slit-like orifice, and usually sort of and then you have a bigger space. Yours is too tubular to be a diverticulum. So yeah, I would call that a blind ending tracheal bronchus, or
Okay.
aborted tracheal bronchus.
Okay, very good. So, so I just want you to know, you mentioned the word tubular. In California, in Val speak, back in the 80s and 90s, tubular was used to describe the particular configuration of the waves. It had a really nice tube to it, man, and it had that concavity that they could just sort of skate along for a long direction sideways. So tubular, to say that something was tubular was a term of approbation. So you could say about this tubular man, that's tubular. Okay, Jeff, so it includes a cultural lesson for you.
All right, that was good. All right, well, thanks everyone. Those were good cases. I will talk to you next week.
Thank
Thank
you all.
you.